So I really want to talk a little bit about diagnosis. And really, there's been a huge focus of discussion around BMI as literally an appropriate means to label people with the diagnosis of clinical obesity or not. And then talk to you a little bit about terminology, where we may be headed with that in the future. Next slide. So, obesity, overweight, however you want to classify it, the terminology has been around for a long time. The insurance companies have known that it's associated with increased morbidity and mortality in patients, and they are actually the ones who really started paying attention to that as they adjusted our life insurance premiums according to our weight. And they actually have actuarial tables that were used by Metro Life before the 1970s. So they're really the first to have any use of those tables, and it was extrapolated on into health insurance coverage after that time. The BMI was really catapulted into use in the 1980s and really has become the standard by which we judge patients' sizes and diagnoses. Waist measurements are really pretty good at helping with the diagnosis of central obesity, waist measures as well as waist and hip ratios, just not quite as easy and not as reproducible depending on different users. And honestly, the standardized measures are really poorly studied and understood. Next slide. So percentage of body fat really sounds like a lot more accurate method. The problem with these methods to determine percentage of body fat is either they're too complex, like the water immersion plethysmography, versus skin fold, which is very inaccurate and user dependent. There are less complex ways to determine percent of body fat, but they're more expensive, take more time, and that's bioimpedance, DEXA, and air displacement. All those things are used a lot more in the gym setting and in athletic training, but they are pretty accurate at determining the percentage of body fat. But as far as medical use, we really don't use them except in weight loss clinics. Next slide. BMI was really developed over 200 years ago. It was by a mathematician and was not developed for use in the medical field at all. This mathematician had in his mind a normally framed man and found that the weight was correlated with the height in meters squared, and came up with a table of BMI. And just to reiterate, this particular derivation of a formula was utilized with the Caucasian population at the base of the formulation. Next slide. So this is the World Health Organization categorization, has been in use really since the mid-1980s. We went over this last time, and all of us know this. Class 3 obesity is categorized as morbid obesity by our insurance coders, and 50 or greater is classified as super obesity. Next slide. So the drawbacks, and AMA has really published a lot recently on this, but from as early as 2010, the AMA Journal of Ethics, they had a publication that really talked about the inappropriateness of use of BMI in medical management. The simplicity has led to widespread application to general populations without much study being used. It really does ignore waist size and central obesity. And the problem with it, it does not allow for bone mass and muscle mass to be incorporated in that. Next slide. This is interesting, and I really hadn't realized this until I was reading some updated literature and studies of the utilization of BMI, and that is that 40 to 50% false negative rate with use of BMI labeling patients as obese. So 40 to 50% of patients are found to be normal with BMI that have excess body fat and are at risk of increased morbidity and mortality associated with that increased adiposity. On the other hand, there's an 8 to 10% false positive rate of diagnosis with BMI. So the patient's labeled as obese, but they have a much higher muscle mass and truly are not obese. And one of the things that a lot of people don't realize is that Black patients have a higher muscle mass than Caucasians and a lower amount of body fat in the general population. So they account for a large percentage of those that are falsely positive labeled with obesity using the BMI. That just doesn't take into account the fat distribution. Next slide. The pros of BMI is easy, it's cheap, it's easily reproducible, and it's already being utilized around, particularly the United States. It's used around the world, but not used nearly as much medically and for coding as we do in the States. Next slide. So in the AMA statement that was recently published really put the onus on us as clinicians to make sure that we did not utilize this as a sole criteria for obesity. And they also put the onus on insurance companies not to use the BMI as a sole criterion for insurance reimbursement. They stated that the classification is misleading, again, because it doesn't take into account bone and muscle mass. And they added the last statement to their ethics statement that because of the flawing of the use of BMI in the classification, it is harmful to communities of color, again, because of the differences in bone mass and muscle mass in the different ethnic and racial groups. Next slide. Terminology we're going to get into, and this is a little bit harder for me, is obesity considered a chronic condition or disease, or is it a risk factor for disease? We know it's associated with an increased risk of morbidity and mortality. Next slide. So, next slide. There we go. One of the problems, we all know this, I struggle with this. Obesity, just the term itself, is associated with a huge feeling of negativity. Patients feel as though there's a lot of blame put with this word, and the bias is really unbelievable. And I fight it every day because I see so many of these patients, and it's very easy to become frustrated. We need to have a change in our approach with these patients. The question is, do we need to make a name change for obesity? Is obesity the proper way to really term these patients that are overweight? Next slide. So, you know, we changed diabetes some time back. The American Association of Endocrinology really tried to make a focus on difference between the statement of diabetes versus people living with diabetes. And now the push is really to change from obesity to people living with obesity, believing that it's associated with less stigma and negativity, and really trying to focus on whether this patient that's living with obesity has any medical complications associated with it. Next slide. seems to be splitting hairs a little bit, but I can understand as we go through this how it might make a difference. The Lancet Diabetes and Endocrinology Commission on Definition and Diagnosis of Clinical Obesity is looking into a name change for the clinical diagnosis of obesity. And they believe that it is so stigmatized that you need to just start from scratch, give it a new clinical definition and terminology. There are 60 members to the commission of many different varied fields. The report is expected to come out this fall. Next slide. And the two names that they're leaning toward are adiposity-based chronic disease, ABCD, easy abbreviation, easy to know. But the problem with this is it's talking about the physiology, but really doesn't tell you what it is. And then the other term is just clinical obesity. ABCD has already been adopted by the American Association of Clinical Endocrinology. So there's a big push for that one, but we will see. And this will be put out over the next few months, and we'll bring it up again later for your knowledge when that happens. Next slide. So AMA in 2013, and they reiterated this in 2021, stated that they like the terminology clinical obesity, and they equate clinical obesity with the definition of chronic relapsing disease, which in turn acts as a gateway to a range of other non-communicable diseases, i.e., hypertension, diabetes, etc., all those cardiovascular complications that can occur with clinical obesity. Next slide. So how can we help take care of these patients better, and how can we minimize our biases in dealing with these patients? There's a huge impetus in making the push for counseling all patients on diet and weight gain, not just the obese patients, making sure that we approach every patient the same, talking to them about the benefit of a healthy diet, half a plate of vegetables, a fourth plate with protein, and a fourth with carbs, really making a push to enhance the healthy living that our patients live on, focusing on the overall health and medical risk associated with being overweight, and using a patient-centered counseling approach. And patient-centered counseling, it sounds like we all do that, right? I mean, we like to at least think we do. But it's difficult when you have limited time for prenatal visits to talk as much about that. And that's one of the things that I love about having dietitians and midwives and nurse practitioners in our office that can spend more time with these patients, and they do a great job with this. We need to understand that obesity is a medical condition, and we need to impart that wisdom to our patients. And most importantly, and this is something that I hear every day when I deal with patients who suffer from clinical obesity, and that is that these folks have had generally many negative experiences within the healthcare system and with other healthcare providers, and they're felt to be demeaned. They are treated as though they're lazy. They are not smart. They're not attractive. There's just so many biases. So I think it's critical for us to approach these patients with sensitivity, understanding that stigma related to obesity and being overweight is a real deal and really is hurtful to these patients. One slide on bias and ethics with obesity doesn't do it justice. ACOG has a whole committee opinion based on obesity and ethics in medicine. The AMA has many, many articles that they've published, and I'll try to give you one reference toward the end of the talk so that you can kind of go back to that. There's a good article that you can read that I think gives a lot of insight. Next slide. So weight gain in pregnancy, I just put this up to mention it. I'm curious from Dr. Elam and others as to what they have done in the past. I used to, when I was in Charleston years ago, we really pushed patients that were morbidly obese in particular, and particularly the super obese patients, to either have no weight gain or less than 11 pounds weight gain during pregnancy. This is the World Health Organization recommendation and the Institute of Medicine recommendation, and that is if they're 30 or over BMI, to encourage an 11 to 20 pound weight gain, and if they're normal weight, the 25 to 35 pound weight gain. Next slide. I show this slide because I think it has opened our eyes a little bit to some information that's been around for a while. Newer studies are out looking at weight gain in the obese patient as well, and how it affects fetal weight gain. But if you look at that middle line, less than 11 pounds gained in obese patients associated with a 9.6% incidence of SGA, small for gestational age, versus a 5% incidence in those patients that gain over 11 pounds. So there's definitely an increased risk of smaller babies. In my mind, is that necessarily bad? And that's the question that has not been answered. Other studies have shown a slight increased risk for fetal growth restriction at less than the 3rd percentile in patients that have gained less than 11 pounds when they're overweight as well. So it's just something that you need to be aware of. Next slide. We talked about this a little bit in the last talk, and that is, I think we have to continue to push our facility management folks in the hospitals as well as in our offices to give us the things that we need to manage these patients appropriately, with appropriate birthing beds for weight limitations, monitoring equipment, and consider staffing it, et and the impact that it has on our staff as well as physicians and providers taking care of these patients, the impact that their care takes. Next slide. We're going to have another talk on these motivational interview methods in an attempt to promote weight loss and diet modification with exercise in these patients. But preconception care in patients who are overweight and have clinical obesity is critical. While normal BMI is the goal, there has been shown to be a significant improvement in health, even with a 5 to 7% weight loss in patients who are over BMI of 30. Medications for weight loss certainly can be used in pre-pregnancy. One just has to be cautious about patient becoming pregnant during the use of these medications. Diet, exercise, and behavioral modification are the basics. And then bariatric surgical interventions and referrals to weight loss clinics can be the mainstay of patients who have severe clinical obesity. Next slide. So these last few slides I just include for your reference. Rachel, I did not put the reference on the bottom of these slides, so I need to give that to you to add maybe when we put these slides out for folks to use. I did not know what the waist size cutoffs were, so I was happy to find this in one of the AMA articles that was recently published. But it also gives the waist size in inches as well as centimeters. And there's another chart that has that for different ethnic groups as well and different races. But the waist size really is helpful in diagnosing central obesity, which the BMI does not specifically take into consideration. And then the waist to hip ratio just adds a little bit more layers of complexity, so it's not used very often. The next slide, go on to the next one if you would. And this is an OHEC graph, but it's just put in here just for me to mention, and you can refer back to it to understand that the BMI is simply a screening tool, and a BMI that's over 30 is not necessarily diagnostic, even though we use it as a diagnostic tool. There are other things that we should consider, and particularly in those patients who have lower BMIs, the push by the AMA and other organizations is to add the waist measurement to make sure that we're not falsely diagnosing or falsely missing the diagnosis of central obesity in our patients, because those that get overlooked with central obesity, we're missing a population of patients that we might be able to have impact on in their long-term health. Not as big a thing in our pregnant patients. Waist size doesn't mean as much in our pregnant population, but it certainly does preconceptually as well as in those postpartum managed patients. With that, I'm going to stop, and you can take the slides off, and I'm happy to have Dr. Johnson and Dr. Bellinger